can now proceed to Mr. Loebsack of Iowa.
Thank you, Mr. Chair. Thanks to all of you for being here today, for your service, and for what you're trying to do to clearly deal with a significant problem within our military. And I think we can all agree that, as was mentioned, that even one suicide's too many. And I appreciate your take on what progress means, what success means, and going forward. As was mentioned, I think everybody here is all too aware that it's not just the active duty folks that we have to be concerned about, but it's the reserve components as well. And that was acknowledged, and I very much appreciate that, especially at a time when, I think it was mentioned too, we have a lot of economic problems, unemployment, what have you. A lot of these reserve folks, these National Guard folks come home, they can't even find a job. Maybe their spouse has been put out of work. They have a lot of family issues. And what's interesting too, last year, half of the Army National Guard soldiers who committed suicide had never been deployed. So it's not just a deployment issue, although it is that too. In the case of the Iowa National Guard, we just had about 2,800 or so National Guard return from Afghanistan this summer. Many of them had been deployed multiple occasions. But again, it's not just a deployment issue. I think that's something that we all need to acknowledge. We also know, as you mentioned, that it's particularly hard to get to Guard and Reserve folks because they don't have a base where they're located, where they would perhaps have access on a regular basis to mental health professionals. So it's a particular problem when it comes to the reserve components. That's why I introduced my Embedded Mental Health Providers for Reserve Act. And thanks to the chairman and ranking member, we did get that incorporated into the National Defense Authorization Act. And that's designed, of course, to increase access on the part of our reserve components to behavioral professionals, whereas they wouldn't have that normally when they don't have a regular base that they're attached to. But if you would, Dr. Woodson, what is the military doing at the moment to try to reach those reserve components in particular, and are we being successful with that? Is that access available? And are folks, in fact, taking advantage of whatever services there may be?
Thank you for the question. It's an extraordinarily important one. Our reserve component service members contribute so much to the defense of this nation, and clearly they need not be forgotten in terms of all of their needs. My answer is along several lines. First of all, we do appropriate post-deployment screening to identify individuals at risk, and referrals are made. So on the immediate front end, we do everything possible to identify individuals who might need care. But we know issues like PTSD and other mental health issues don't show up immediately. And of course, we've got transitional assistance medical care. They do get TRICARE benefits for 180 days, and in cases where it's identified as service-connected, it can be extended. But more importantly, we partnered with the Department of Veterans Affairs to really open up all of their assets and services in terms of mental health services to reserve component service members. Also established is that within the 54 states and territories are state behavioral health counselors whose sole job it is to coordinate care for reserve component service members and allow them to get access to care and to be, if you will, staff counselors to commanders to ensure that they have the appropriate programs and access to care. And then finally, let me just say we've partnered with the Department of Veterans Affairs to address the issue of reserve component service members in rural areas by really enhancing the whole concept of telebehavioral health. And this is a very interesting concept which will allow via internet connection for someone who might be in crisis or have a problem to talk directly with a behavioral health specialist and get care. And preliminary results suggest that it's a very acceptable means to provide care. So along a number of different lines, we're trying to address this very important question.
I appreciate that. I think it's really important, too, that CBOCs, where, especially in rural areas like Iowa and other places, those CBOCs provide mental health care as well. I think that's really critical. But again, I want to stress that half of those suicides that happened were for folks who had not been deployed yet. You mentioned post-deployment. I think we have to think about pre-deployment, too, and that's why I think it's important that we do embed mental health professionals, or at least make sure that people are aware of the situation prior to deployment when they meet on the weekends, when they get together, and their families as well. Thanks to all of you. Appreciate it. And thank you, Mr. Chair.